Hello, my name's Daniel Lawrence, childhood physiotherapist. Welcome to the series of online lectures on exercise for pain relief. In this first lecture, we're going to have a look at therapeutic exercise mechanisms. I'd like to start by proposing this first slide to suggest the idea that strength and conditioning coaches use exercise differently than therapists. There are of course some similarities, and therapists can learn a lot from strength and conditioning professionals, but whereas a strength and conditioning coach may be more concerned with performance measures, a therapist is often aiming to reduce their patient's pain. And therefore what they're looking for from exercise can be different. So a strength and conditioning coach is typically looking to improve strength or endurance or cardiovascular endurance, whereas a therapist is looking to reduce pain and make some positive changes to the patient's lifestyle which are sustainable. But of course both groups will be looking to use exercise parameters correctly and to bring about positive sustainable changes, and also to create programs which are achievable for each individual. So we now know from pain education that there's more to pain than something being damaged, and that tissue damage doesn't always equal pain, and that pain doesn't always mean that there's some tissue damage. But there also seems to be more to strengthening than muscles simply getting stronger, and there seems to be more to rehabilitation than improving the strength of tissues as well. So as an example on the screen here, you can see that the typical way of thinking would be that if somebody has a painful knee, we would then test that knee and often find that the knee was weak, and then we would form a rehabilitation plan to strengthen the knee, and that we'd then hopefully see some changes in pain, some reductions in pain and improvements in the patient's function. But what are the mechanisms behind this? It's not just as simple as getting somebody stronger and then experiencing less pain, because the research shows that reductions in pain don't always come in line with increases in strength. And we can see opposing results where we see, for example, improvements in strength without reductions in pain, or we see reductions in pain without actually any measurable changes in strength. So what are the mechanisms at action here? Well, if a knee is painful, that could be due to tissue damage, of course. It could be due to disuse and some sensitization of the tissues. It may also be due to social influence and vicarious learning, for example. So information that patient has gained from internet research or from speaking to friends or colleagues can also have an influence on the pain that they're experiencing. Why is the knee weak? What are the mechanisms at play here? Well, it could be simply down to a very basic physiological atrophy of the muscle tissue around the area, but it may also be down to losses in motor control from disuse. It may also be an element of kinesiophobia, where the patient is afraid of pain from movement, so is therefore not loading the area out of pain rather than because it's weak. So the lack of use has caused the weakness rather than the weakness causing the lack of use. There may also be some changes in the brain, some cortex changes, where that area of the body, its representation, has been reduced following the disuse of the area, or the precision of the motor control of that movement from that area has diminished and somewhat smudged, reducing again the motor control, and that sometimes correlates with increases in pain as well. So when we strengthen the knee, it's often likely that we're looking to put some load through the knee, but research also shows that pain education can be a powerful way of not just reducing pain, but also improving strength and function as well, as the patient is more willing to load the area. Research also shows that simply imagining muscle contractions can improve strength or reduce strength loss following immobilization periods. Strengthening also offers an element of exposure, as the patient is exposed to movements which they were once avoiding, and therefore shows them that they can do those movements, they can load the tissues, and this can bring about changes in strength as well, as they're simply more willing to load the area. So why does less pain occur? Well, it's not as simple as strength, as you can see. It could be due to from reduced threat and the increased knowledge from performing a few repetitions. It could be due to improved motor control, which then allows the sharing of load between the tissues in a better way, therefore promoting better movement. Knowledge may also bring about less pain, as that MRI or X-ray that they've had is put into context. They may start to become less worried about some of the structural pathologies that were communicated to them. And Something which we'll look at more in depth in lecture 3 is descending inhibition. This is the idea that if you engage in cardiovascular exercise or strengthening exercise, that you get a period of reduced pain sensitivity following the exercise, and there doesn't seem to be too much specificity with that. In fact, the positive outcomes can be quite broad. So we can see reduced pain from other measures that are not linked to the physiological changes in the tissues. So I'm now going to show you 3 slides which group together the potential therapeutic exercise mechanisms. And this looks at why exercise works to reduce pain, because it's about so much more than simply improving strength and hypertrophy and physical changes. But physical changes are absolutely involved. For example, we should see improved strength measures following strengthening rehabilitation. And this can help to build reserve strength capacity. What I mean by this is if somebody is walking up the stairs and they're using 90% of their maximum strength, then they're working very hard and they haven't got much reserve left or much buffer left in the system. If they engage in a strength and conditioning program, then when they walk up the stairs, they're only working at 60% of their maximum capacity, then suddenly they've got a 40% reserve, a 40% buffer zone, and they're working their system at a much lower level. So by improving strength, we can make normal day-to-day tasks feel easier and be easier on the body's tissues if they're able to tolerate much more load thanks to their adaptation through training. Good quality exercises can also help to improve the speed of the muscle contractions. And this has been shown to be in deficit following an injury, and muscles that contract quickly can be very helpful for reducing ground reaction forces. And we also see that in the upper body, the muscles around the neck, for example, have to work in advance of shoulder movements in order to bring about the correct stability through the central part of the body. Muscles need to be more than just strong. They need to work effectively when they're needed and to contract quickly. Our exercise interventions may also offer the patients new movement strategies, allowing them to perform functions in the absence of pain, thanks to an improved awareness of their body and the sharing of load between different joints, and simply just exploring new ways of movement which may be more comfortable and less threatening for them. Our exercise interventions may also improve movement range as we desensitize the tissues and perhaps desensitize the stretch reflex. And this improvement in range may allow day-to-day functions to be that much easier. For example, bending over to put shoes and socks on may become much easier following a spinal flexion exercise routine. Our exercise interventions may increase muscle tone, and this may be a positive thing for the patients as it helps them to move around more confidently and with less pain. Or, depending on the starting point, we may actually be looking to reduce muscle tone and reduce that feeling of tension, particularly around the lumbar spine. And again, this can have a positive influence on the patient's pain. So it depends on the starting point and the goal and the exercise intervention in between as to whether we look to increase muscle tone or decrease muscle tone, whichever one works best for the patient. We may also be looking for improvements in posture. Now, I know posture's had a bit of a bad rap lately, and the research has challenged the idea that posture is influential for pain, but posture is still something that many patients are aware of and many patients think about, and posture can have an influence on many parts of our body. For example, our posture can change our breathing mechanics, and different postures can load the tissues in different ways as well. So yes, it's not all about posture, but posture is still something that is talked about, patients want to talk about, and we can positively advise patients on as well. And also the physical exercise is most likely to help improve the patient's balance. And improving balance is never a bad thing. This next slide looks at the psychological mechanisms by which therapeutic exercise may work to reduce pain. The psychological elements can be the most influential at determining whether the exercise interventions will work or fail. Hopefully, if the patient has a positive experience of exercise, they should experience an improved mood, and this certainly helps to set the scene for further positive outcomes. Exercise and the sense of control can also improve confidence and self-efficacy and promote that internal locus of control and reduce the likelihood of learned helplessness, as the exercise program is typically something that the patient has to engage in themselves. The exercise is also a form of exposure therapy, as it allows the patient exposure to movements and to load, which they may have been avoiding before the supportive therapeutic intervention was put into place. And this may allow the patient to have an improved pain tolerance. As they're aware that the pain does not equal damage, they're more willing to load the tissues and more willing to accept a level of pain. And exercise in the presence of pain and discomfort can often lead to more positive changes than if patients are constantly trying to avoid any form of discomfort during their exercise. The patients may have started with some maladaptive beliefs regarding their condition, their pathology, and the likely outcome of exercise. So if they've had a positive experience, then that helps to extinguish those maladaptive beliefs and is really just a part of positive, successful exposure therapy. As we discussed on the previous slide, finding new movement strategies which are more comfortable and more favoured by the patient also links into having more coping strategies, so the patient is able to find ways to self-manage their condition as they're encouraged to expose themselves to movement, expose themselves to some levels of pain, and that encourages them to find ways to cope with this so they can improve their day-to-day function. And here we should see some reduced kinesiophobia as the patient is less fearful of pain and less fearful of movement based on their previous positive experiences. Psychologically, we can also look to remove any signs of ex-consequential reasoning. Now, this is a bit of a mouthful, but what it is where a patient perhaps feels some aches and pains or niggles or clicking or grinding from a joint and associates that with joint damage and with a problem. So we can educate the patient that aches and pains are often seemingly normal, and that clicking from a joint, for example, is again something that's quite normal, but a patient may become more aware of it if they have some pain from that region, for example. So we can educate the patient that these physiological feelings that they have don't mean that there's damage occurring and don't mean that it's causing a further problem. So removal of that ex-consequential reasoning is one of the key things that we're looking to achieve when we tackle the psychological elements of therapeutic exercise. Next on the slide we have latent inhibition. So if a patient has had a positive experience of recovery before, they're more likely to expect and therefore achieve a positive recovery the second time round or third or fourth, for example. So once you've achieved some positive outcomes from rehabilitation, then the next time the patient has a problem, they're more likely to have a better prognosis as they're almost expectant of a positive result as well. So that's latent inhibition. It's previous positive experiences helping to reduce pain with current experiences. On this last slide, I've grouped together the neurological, the endocrine, and the immune responses. Exercise should hopefully lead to some central nervous system desensitization and also reduce cortical inhibition. So if the brain is not fully engaging the motor system, then the brain can look to restore that so that motor control is improved and motor output is normalized. Through movement and precision movement, we can also look to restore cortical representation so that areas of the body have the correct representation in the cortical mapping in the brain, but also that the brain has the effective strength and precision in the motor system to effectively engage the peripheral muscular system. Desensitization of the peripheral sensory nerves may also occur, as well as improved muscle fiber recruitment. So the same muscle tissue is performing at a higher level, or its dysfunction has been restored by normalization of the motor input. Next, we come to descending inhibition, and we can categorize this into three subcategories. One is the endogenous opioid system, the other is the endocannabinoid system, and the other one is the serotonergic system. Again, we'll talk about these further in lecture 3, where we look at exercise-induced hypoalgesia. Depending on the level and intensity of the exercise, we may also promote immune system changes with the release of anti-inflammatory cytokines helping to dampen down an inflammatory response. Furthermore, the intensity of the exercise is influential on the stress response, with the release of adrenaline and cortisol having an effect on the body's pain mechanisms. Okay, so that brings us to the end of lecture 1, where we looked at the mechanisms of exercise for pain relief. And the idea was not to add too much complexity to why exercise works, but instead to show that there are many influencing variables, and being aware of them is important, because if we can manipulate those in clinic, we can improve our patient outcomes. So please join me for lecture 2, where we look at strength, pain, and the brain.